Good morning, everyone. My name is Ariella Herman, and walking here today, I was thinking, how can I share 25 years of my life in 20 minutes? But I will try. These are the points that I would like to cover today. Some information about the Healthcare Institute and what makes us different. What is the innovation in our implementation? What are the evaluations and outcomes that we've had, and where do we go from here? So this specific presentation is about our work with the Head Start community. So as you probably all know, Head Start is a federally funded program that serves the most underserved children and families in the United States. 1 million families are served every year. In addition to education service, Head Start is in charge of providing comprehensive health services to their children and families. We have been lucky enough at UCLA to have a grant for the last 27 years from Johnson & Johnson, where we bring every summer Head Start director to train them on management. So in the year 2000, I did a survey with 600 of these directors and asked them, what are the major barriers that your family face relative to health? And the answers were not at all what I expected. The answers were the lack of health literacy and also the lack of attendance, given all the obstacles that these families have to come to training even when they are offered. So we created the Healthcare Institute in 2001 with the mission to strengthen the managerial capacity of Head Start agency so they can provide more effective health education and prevention program. And by more effective, we meant increase the usual attendance that was 25 or 30% to above 80, and also give materials that they could understand and could be actionable relative to their health. So our strategy really has had two parts. The first part was to give Head Start agencies and Head Start communities strategic management tool that they can use to assure successful health education and promotion, and at the same time provide materials that were culturally sensitive and low literacy that would help them engage and empower them in their decision making. So far, this is where we have been. We were lucky enough to have funders that really made our process so much easier. Johnson & Johnson has been funding us for the last 16 years, which really allow us to develop slowly and to collect information, develop partnerships with the Head Start communities. We then got an innovation grant from the Office of Head Start, which really led, I believe, to our strong conviction that health literacy is such a cross-cutting element in health, that in the national centers that are funded by HHS that work with Head Start, health literacy has been included, which is a wonderful outcome, and we've had additional funders. We've reached so far 140,000 families in all ACF region, in 50 states, different community types. We did the training in 7 languages, 10 ethnicity. Our main base was Head Start and early Head Start, but we have started expanding to childcare. What we learned in the last 17 years that makes community-based health literacy more effective. First of all, the use of business management tools is really a key to success. For each agency to define goals, objective, and action plan. Very important, getting the commitment of the leadership, giving tools that help agencies to create staff, parents, and community engagement, low literacy material, 3rd grade or 4th grade maximum, flexibility so agencies can implement it locally, since Head Start has rural and urban and Native American and migrant community, and applicability to multiple health topics, and continuous improvement using data. And all this was glued by what we called love. And love stands for listening, observing, valuing, and encouraging. This was created by a Head Start director. And when this trickled down in a community, it really strengthened the impact. So this is the strategic implementation model. And you see there are multiple steps because no change happens without intention and without really planned activities. We start by bringing Head Start agencies to a train-the-trainer, where we share with them the management tool on how to strategically implement the health education and health promotion. They go back and then they train their families on different health topics. After the training, we found that nobody changes knowledge or behavior after one training, so there's a reinforcement period with multiple methods. And all this model is really sustained by what we call the Health Improvement Project, or HIP. Now, in the Healthy Improvement Project that every Head Start agency has to do, they start by understanding who we are, then they will define goals and objective on what they want to reach. They start by thinking how could they engage their staff so they could engage their families, and the engagement of the community, whether it's medical community or the business community, identifying the resources, program implementation, and data collection. So data collection has been part of our model since the beginning. Some pictures that I believe express this implementation. This is a training in 2 languages, English, Spanish. The tool that we've used are the What to Do book from the Institute for Healthcare Advancement that exists in multiple languages. This is a training in 4 languages in a Head Start agency. They translated all the material, in addition to English and Spanish, in Hmong and Somalian, because this is what their population was. It really looked like the United Nations, but every family got their training. This is a training that happened in Seattle that happened in 7 languages. So what we found is that we're not trying to change tradition. We're trying to give understandable health tools to families so they can take action relative to the health of their children. Pictures that always say more than any chart or data, training in the Native American community, very hands-on training where we really teach the core of what families of young children need to know, starting with common childhood illnesses. And what you see on the top left is a training that happened during Katrina in a shelter, and they called the training, "There's no place like home." So these are the hopes that drive us in our quest. To be able to evaluate this program, and since we had the luxury of time and building it step by step, we really have 5 levels. I will not share with you all the levels, but just some examples, starting with reaction, going to learning, behavior change, leading to organizational change and sustainability, and then leading to policy change. So if we start first with knowledge and behavior change, these are the kind of measurement that we took, a lot of pre-post survey to look at knowledge and behavior change, but also tracking of behavior, of emergency room visit, tracking of children's absences and reasons from school, but definitely the qualitative stories and the feedback. Now, one key to our success was the development of this partnership with the Head Start community nationally. they knew we were on their side, and together with us, we would get the feedback and share with them the results. So on these two levels, here are some examples from our data collection. When your child is sick, would you first go for help? You see the huge change before the training. 75% go to the doctor or emergency room. How it drops down with the use of a health book that is written in third grade literacy level really becomes the first source of help. When your child had, what would you do when your child had 99.5? And it's surprising to find that many people do not know what 99.5 is, and that they use the emergency room or the doctor. That's why the hands-on training, showing them how to measure the temperature, really showed over time a change in behavior. We also have tracked the school day missed for the children, and when we talk about school readiness, we found close to 30% of drop in school day missed, and also work day missed for these families whose work day is so important. And when we tracked emergency room visits and clinic visits, you can also see, okay, that during 2001 and 2008, we saw the same trend with a drop in doctor visit and emergency room visits. All this data was combined by the qualitative outcome, which showed an increased parental awareness of health warning signs, prompter response to signs of illnesses, appropriate use of a book. When they understand the book and they know how to use it, they keep it, better understanding of common childhood illnesses, better communication with healthcare providers, and definitely an increased engagement. Working with the Head Start communities, where it starts with pregnant moms and it goes to parents 0 to 5, this is really the perfect time to start engaging families, because they care about their children, and when you give them the right tools, it definitely makes a difference. And among mail that I receive, I would like to share with you this one. A parent who has tools to make appropriate decision about the health of their child has been given self-esteem. When a person has self-esteem, they can move mountains. Mountains have been moved in the life of the families that I work with through health education with love. So next level of evaluation and outcome is the organizational change and the sustainability that we've had. First of all the grantees have implemented the health improvement project far beyond the years where we were funding them. We did long-term impact surveys of grantees that we trained 5-10 years ago. We saw an increased cross-sector collaboration with the communities that were here, and also the fact that although we started with common childhood illnesses, we saw that the model is adaptable actually to any health topic. So for the sustainability study that we did, we sampled about 203 Head Start agencies from 50 states, and what we found is that 84% of them sustained the HCI activity beyond the initial year where we trained them and funded them, and 71% continue to provide this training on a yearly basis without our help. That the key predictor to sustainable success were, first of all, the engagement of the stakeholders, and the stakeholders being the leadership of the Head Start community and the community in which they were living, continuing to provide incentives and remove barriers for these families to come to a training, or even include it in their training budget that allowed them to do it. Now, many of our agencies have been keeping sending teams to our training in such a way that turnover doesn't stop this program from happening. Some more results relative to the survey. 70% reported that they continue to leverage community resources. They were able to continue to provide incentives to parents, and they were able to continue adapt it in their environment. The leadership team, crucial. You have to know that whenever we do the training, it's mandatory for them to send the leadership team, because without the buy-in of the leadership, they cannot do this implementation. And staff engagement, staff that works in early childhood education are themselves burdened and overstretched, so their engagement is really important. In 2017, this year, we created a new online survey, and we wanted really to continue looking at what are the critical elements that continue this strong, impactful health education and also family engagement. Because what grantees saw is that once a family came to one training, they were standing in line to come to others. Every parent want this kind of information if it's given to them with respect and with materials that they can use and understand and that is adaptable to their needs. And from the survey, what we found is that the most important aspect to continue to engage families is providing a meal, and a meal means a lot for these underserved families. But next come the low literacy messaging, which is such an important element. In terms of the elements from our training, as you see, the Health Improvement Project kept these agencies, kept them doing it over and over in a strategic way, combined with the tools. During our training, we specifically give them tools on how to message the training to their staff, to their families, how to show the community what is the value added to them, whether it is the health community or the business community and staff motivation. Now, over time, we found that this model can be adapted to other health topics. And this is the example of some of the health topics that we have developed: oral health, diabetes, obesity prevention, prenatal. And I just want to share with you the oral health one that we call Eat Healthy, Stay Active, because this is the first model in which we really combine three levels. We train the staff, we train the families, and we train the children at the same time to have a stronger impact, both on knowledge and on behavior. And our data showed that we've seen a significant increase in knowledge and in behavior relative to healthy eating. These are surveys of 4-year-olds, and you can see the difference between the beginning of the year and the end of the year. Children are like sponges. We've had an impact on BMI between the training and 9 months after the training, both in children and in families. And this is the creativity of Head Start, creating a farmer's market where they teach children how to buy, bring the food in the classroom, learn about calories, about numbers, about mathematics, and then cutting and tasting. So last but not least, the 5th level is the policy changes. So what we've seen is that we've seen changes in system level in the Head Start grantee themselves, but also in the Office of Head Start policies, and right now also in the Head Start new performance standard. So health literacy was included, and I believe because of our fight, in the National Center for Early Childhood Health and Wellness. And this year, for the first time, health literacy has been included in the Head Start performance standards, and we're very proud. And what we found out, which we didn't know, is that actually the Healthcare Institute really works with multiple of the performance standards that say, in addition to health, Head Start agency need to use a strategic implementation and need to make sure that they engage the families and the community. Greatest challenges, funding, okay? Explaining how every element is important. Cutting corners doesn't work, and we tried. Giving the material didn't work. Just removing barriers didn't work either. Challenges, how do we embed it in other programs beyond Head Start? How do we create advocacy group among the parents that have gone through this, and how can we link it to medical schools and medical students? And as my final message, we have seen through our work that family engagement is fostered through health literacy and a management system approach. Once the parents have the knowledge, the tools, the motivation to protect the health of their children, and you remove the barriers, you can really see change. So a systematic approach to community-based health literacy, we can really make a difference. Thank you very much.